All right, so at 12:30, we'll get started now. So good afternoon, everyone. Thank you for joining the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So thank you all for muting your microphone once the presentation begins, being attentive to the presenters, keeping your camera on, being engaged in the session, and completing and submitting a session eval form. All right, so here's the activity code for today. I'll leave this up here for a little bit so you can all get this down. All right, next slide, please. And then this is just more information about getting the credit via text. I'll leave this here for a bit as well. Thank you. Yeah. All right, next slide, please. And then this is just information regarding CME transcripts and how to do that and get those. All right, next slide, please. And then this is just information regarding the AAFP credit system. All right, next slide, please. And then this is just information regarding the core competencies. All right, next slide, please. So Dr. Neela Patel has no financial relationships with ineligible companies to disclose. Next slide, please. And then Dr. Nato for your introduction.
Yeah, thank you. It's a pleasure to introduce Dr. Neela Patel to do our grand rounds today. Neela was a resident here from 2005 to 2008, and then did a geriatrics fellowship, finished in 2009, and a research year after that. And then she's joined the faculty, the geriatrics faculty, and has been one of the leaders over there for a decade plus. She has multiple publications in that area, as well as multiple national presentations. I'm not going to go on and on too much, but I really appreciate her bringing her expertise to our grand rounds today. Her topic today is age-friendly health systems, what matters most. So I'll turn it over to Dr. Patel.
Thank you, Dr. Nato. Good afternoon, everyone. So I'll be focusing my presentation a little bit on the age-friendly health systems, but a lot more on what matters most, which is one of the aims of the age-friendly health systems that focuses on advanced care planning and advanced directives. So basically, I would like to touch upon defining what is advanced care planning and advanced directives, explain when, where, and how to start as family physicians, and identifying how to make shared decisions, how to engage our patients and family in making these decisions earlier on, and demonstrating the impact of advanced care planning. So age-friendly health systems, just like how we have the patient-centered medical home for standards for primary care, for geriatric primary care, we have the age-friendly health systems Our practice is an age-friendly health system practice recognized by the Institute of Healthcare Innovations. It started off as a 4M framework, but now it is actually a 5M framework. What matters most is focusing on individual preferences, medications, mentation, and mobility, and we'll briefly touch upon each one of these.
Thank you.
So what matters most is very important for us, especially as family physicians, to know and align our care with our older adult patients specific to health outcome goals and care. So as I tell my patients, getting older is life, and getting older is not a disease. And so really, as we get older, it's not our routine algorithms or medications that's going to help make life better, but what changes we make to our changing physiology and anatomy as we get older, and what are our values, what are our preferences that are important for us in making decisions on how we want to live as we get older. Medications, as mentioned, medications are not a fix, and medications that younger patients take may not necessarily be what older adults need. A classic example being diabetics who've taken large doses of insulin when younger. As we get older, you lose body and muscle mass, and the insulin is not as resistant as it was when younger, and we may not need as much insulin as we've needed before. Medications, so as we all get older, we have chronic conditions and generally are taking some medications for them. Polypharmacy has various different definitions, but generally more than 5 prescribed medications is considered as polypharmacy. The more medications a person is prescribed, there is a higher risk of not taking the medications consistently on a daily basis. There's chance for medication errors. And as we get older, kidney function is different, metabolism of medications is different. The drugs interact with one another and they stay in our circulation for a longer time. So the side effects are much more. And then the prescribing cascade. You prescribe a medication, they have some dizziness with it, so you prescribe another medication, or they have a side effect. And instead of reducing the dose of the medication or taking away the medication, we, without intending to, end up with a prescription cascade. The drugs interact with one another much more. And then there are drug-disease interactions. Some conditions we have, and you take a drug and it makes the condition worse. This is a patient in clinic that had come with all their medications, and basically I put in only the prescribed medications here in this picture, but not the other non-prescription medicines that the person had. And these 5 medications are basically all different doses of lisinopril, 2.5 milligrams, 2 bottles of the 5 milligrams, one was 10 milligram and one was 20 milligram. So the person was having like a dry cough with it, never mentioned that they had the cough, didn't like how they felt with it. And we kept on increasing the medication dose without realizing that the person is not taking the medication, and that's why their blood pressure is not controlled. And many times as primary care, we do a very good review of medications, but patients don't necessarily tell us all the medications they're taking. They will only tell us the medication that we as primary care prescribe for them, but they will not mention the medications that the cardiologist has prescribed, or the nephrologist or pulmonologist or neurologist. So it's important to ask patients to tell us all medications that they're taking, both prescribed and non-prescribed, and make sure that we follow a de-prescribing strategy. Every time we see the patient in any form, whether it's a telephone encounter, whether it's a My Chart or a secure message encounter, or we're seeing them in person, if there's any way we can try to reduce the dose of a medication or reduce the medications. So basically for medications, you really do want to simplify the regimen and try to give once a day medications or a combination of medications instead of two different medications. And always try whether we can, is there a way other than medication to treat the person? Especially they get older, whether it is like for arthritis, especially walking and stretching and flexing is a much better exercise. Just as today I had a new patient as a consultant. She was telling me she went to a pain doctor and he gave an injection only once. But after that, that pain doctor told her, referred her to physical therapy and exercise. I said, well, that's really a very good doctor for having told you that pain and arthritis pain can be managed with exercise, diet. I did mention to you about deprescribing, and after a while, like having done this for years, many of our patients now come and ask us, are there any medications that we can stop taking or have a dose that have a medication dose that we can reduce? Reminding patients about taking the medicines phone or in person. I know we have a spectrum of patients where some can use high technology and phone reminders, and we have another where technology is a challenge. And how do we give them reminders? In our practice, we also have promothoras actually who go and help our patients remember or set up their medication boxes and give them reminders. They even call them to remind them to take the medication. The weekly pill box is like a bone or a vein, because if they are not oriented and they mistake the day, our patients may or may not remember to take the medications, and sometimes it gets very complex. So we try to simplify even the pill box to just a day's medication based on how much support they've got. Are they capable of doing it themselves? Do they have children who come and help, or is it like they have a provider who's helping them to keep the medications? So based on that, and focusing on managing all the medical conditions and seeing the person as a whole rather than body parts, and making sure that we are treating them as a whole person and understanding the relationship between all the different medical conditions they have together, how it impacts the person and their quality of life. And simplifying the number of doctors. Now, I think this is one of the challenge for our older adults, because they have relationships are really very important. And they've had these doctors for many, many years. And then you ask them that you don't need to go to a doctor for every body part of yours, and only for those, like maybe once a year, not every 3 months. You don't need to get your blood drawn every 3 months. It's a challenge, but having established the relationship and trust, they are very willing then to simplify the number of doctors they go to and reduce the number of doctors they go to for reducing the number of pills. So mentation to prevent, identify, treat, and manage dementia, depression, and delirium across the settings of care. And I think in primary care, we do really good in identifying depression and also dementia, at least during our annual wellness visits and all that. And of course, in the hospital, we do screening for delirium. Mobility, ensuring that older adults move safely every day in order to maintain function and to do what matters most to them. Now, mobility is moving. If you don't use it, you lose it. And then even like simple stretching and flexing. I do talk about the sit and be fit. It used to come at 11 o'clock on the PBS channel every day, and they changed the time to 1 o'clock to allow more older adults to engage in that activity, because 11 o'clock was usually the lunch or brunch time, especially for older adults in independent living communities. And the participation was really not as much. So now they have one show at 1 o'clock and another one at 1:30, which is also some stretching and flexing, but that helps to keep the mobility. The other is many older adults with poor balance don't really like to use walkers, and a cane actually is not appropriate for majority of our older adult patients who have poor balance, because it tends to actually worsen the scoliosis and kyphosis for them. They tend to just lean to one side, or the cane may not be the appropriate height or length that they need to have it at. So encouraging them that if you want your independence and what matters most to you is your quality of life and independence, then you're a wise person and you would use the walker so that you don't fall, because one fall can just compromise your ability to be independent. Also telling them about the kyphosis and how that will affect balance and increases their pain and limits their mobility. So choosing a walker over a cane. And chair exercises is good exercise. Now, exercise doesn't have to be for 30 minutes at one stretch. Even if they do it 5 minutes, 6 times a day, or 10 minutes, 3 times a day, any format of exercise. And it doesn't have to be on a treadmill. Many of the older adults, especially in summer, they like water exercises and water aerobics. And so that is a good way of getting the exercise. Yard work also would comprise as exercise. So they mow their lawn, or, plant some herbs or spring flowers or whatever. All that does include come under exercise for both flexibility and mobility. So I typically ask my patients, like, what's a day for you like? What do you do from the time you wake up till you go to bed? And try to get a sense of how physically active they are, how much they move around, how much they socialize. Because for mentation, apart from just diagnosing depression, dementia, and delirium, they really need to focus on having meaningful socialization, and meaningful socialization with the peers and not just with family or grandkids. And one way I encourage them, especially here in San Antonio, we have so many of these senior centers here, which have a lot of the exercise equipment, group classes, and also provide good classes for a healthy diet, food, and nutrition. And I do encourage them to go and try out the senior centers, register there, and at least go for once a week to do it. But so after gauging a sense of what a typical day is, you can try to introduce 1 or 2 things for them to do in their normal routine day that would contribute towards their mobility or contribute towards a meaningful socialization for them. And giving 1 or 2 things that they are willing to engage in. And I suggest a few things and ask them then, what is it now that you would like to try? What do you think you'll be most successful in achieving? So it's just not enough to suggest things and write it in the after visit summary and give it to them, but maybe, even saying, okay, I know you can do so many things, but which of these do you think you're going to be most successful in? And the next time they visit you, or you have an interaction with them, making sure that we follow up and ask, how did that go? What helped them? What were the barriers? Do they see any benefits to what recommendations were given to them? So basically for mentation, we do screen for depression. Depression untreated, the pathophysiology is the same, 5-6 years of depression not treated. They do have a higher risk of developing dementia. Of course, we did mention about the cognitive screening, and I know for busy family physicians where you have larger panels and more patients that we see every day, at least trying to do the mini cog to detect if they need any further testing and need to be referred for further testing. And asking for depression or memory loss. Many times patients who are depressed as we get older, it's not that you're sad, but you would lack interest or motivation in doing things, and also maybe more irate and short. So many times family members will say that they're very, they have no patience and they're always angry or getting angry anytime you ask them any question or anything. That should be a clue to you to further screen them with the PHQ-9 for depression, or even use the geriatric depression scale. And memory loss, sometimes depressed patients will say that they are not remembering things because of lack of interest and not focusing. But when family is saying that they're repeating things or they're having memory, it's more likely more cognitive than mood and depression. Mobility, you do, as I mentioned, daily, what's a day, their ability for personal care and for domestic care. Do they buy their own groceries? Somebody buys it for them. Who does their laundry, cleans up their home? So getting a sense of what their functional ability is. The timed up and go test can be done in our offices. Our office rooms are 8 to 10 feet in size, so you can have them get up from the chair and walk to the door and walk back, and you can do the timed up and go, and asking for the use of cane, walker, and wheelchair. Well, many of our patients do use a walker, but when they come to the clinic for an appointment, they do not have their walker. And I'm asking them, so where's your walker? Oh, I left it in the car, or it's at home. And then how did you get here? And they will say, oh, I held my daughter's arm or son's arm, or, or I managed and came. So asking about that. And many times they come in a wheelchair, and not assuming then that they are wheelchair bound, but asking, is this yours? How often you use it? How long you've been using a wheelchair? And then screening for falls, vision, and hearing. Hearing loss also contributes to cognitive loss. And if we don't ask for it, usually they think it is normal when we get older. It's normal for us to fall. It's normal to have visual problems and hearing problems. Those conditions increase, so cataracts, macular degeneration, more common as we get older, but it's not normal. Something has to be done about it. Same with the hearing loss, and many don't like to wear hearing aids or forget to wear the hearing aids, even though they have hearing aids. And fall, since they think it's normal, if we don't screen for it, they're not going to tell us that they fell. So now focusing on what the fifth M, before we go on to advanced care planning, is multi-complexity. But the American Geriatric Society says multi-complexity because multiple medical problems, multiple chronic conditions, multiple providers, multiple medications. So the complexity of caring for older adults, the American Geriatric Society says the fifth M is multi-complexity. But we focus a lot on persons with dementia or cognitive issues and trying to provide primary care for persons with the brain health issues. So some of us use the fifth M as meals, because not being hydrated, not staying hydrated relates to problems. So hydration, having good amount of protein, and fruits and vegetables. So again, there we ask, what's a typical breakfast, what's typical lunch, what's typical dinner, and try to advise what they can have more of, what they can have less of, rather than printing out a diet sheet for them, trying to make it more person-centered and more specific to the person, and giving a recommendation of 1 or 2 things that you would like them to make changes in. So if they drink only 2 glasses of water a day, can you add on a 3rd one, even though we know they require at least 6 to 8 glasses of water, but making it more realistic and achievable for them, rather than just saying, this is what is needed, and do it. I know we have a really good behavioral health team, and our residency program especially is really very good at incorporating more comprehensive care. So using our team members to help us have our patients achieve their goals for themselves, for what is important to them. So advanced care planning, for years, it has been a paradigm where advanced care planning is always thought about like, how do you want to end your life? But really, advanced care planning is how you want to live your life. As long as we're breathing and our hearts are beating, we have life. And advanced care planning is planning our life and being ready, being ready for any situation related to our health, where there's going to be a change in how we live on a day-to-day basis. That is what advanced care planning entails. and making our wishes and preferences known, making our values and what we would prefer in different situations, and letting others know. By others, I mean letting the family know, because many times families don't know what the values and preferences of their loved ones are, and also letting the healthcare team members know about what is planned in advance. Okay. The different things are making, it not only involves planning for healthcare decisions, but also legal planning, like when we can't speak for ourselves, who's going to be our voice and our spokesperson, our advocate. Financial planning, we are all living much longer, but not necessarily better, and the quality of life. So you do need to plan for that. And retired income is fixed, but cost of living keeps on increasing. And basically care plans for life, as long as you're independent, how you want to live. Should you lose your independence, should you have a diagnosis where you're going to need help of another person, how is it that you want to live and what plans you want to have for that. These are not decisions that are made in one office visit or two office visits, and we've noticed we make these decisions better in our home visits, and better if we have a team like a social worker or a promotor or somebody with us. These decisions are made much better, and we do engage whoever the person that we're caring for feels needs to be as a part of this decision. We either get them in person or you get them on the phone, and find ways to engage whoever needs to be engaged in the meeting to make these decisions. And it happens over time. It's better to make these decisions when the person is healthy and when you know the person and you have a relationship with the person, than to make the decisions, which most of the time we end up doing is when the person is really seriously ill and in the hospital. So when should we start these, advanced care planning is planning for life. Advanced directives is more like a legal document. It has three different components: a medical power of attorney, preferences and wishes of the person for different health conditions, and an out-of-hospital do not resuscitate form. A medical power of attorney and preferences and wishes are basically focusing on how the person wants to live and when the person is alive. An out-of-hospital DNR is a legal document that would come into play only when the person is naturally dead, that is, has stopped breathing or the heart has stopped beating. Many times our patients and actually healthcare professionals too, because many times we see it in the hospital with even our home health staff. Oh, they have a do not resuscitate when the person is sick and actually really needs to go to the hospital to get the treatment they need. So do not resuscitate is not do not treat. And just because a person has a do not resuscitate form, it doesn't mean when they've fallen and broken their hip, or if they have a heart attack or have had a stroke, that you do not treat them. We do treat them. It's only if natural death has occurred, we're not going to give them chest compressions or try to intubate them. Okay. So whenever we talk about who is the right medical power of attorney to choose, it should be somebody that the person trusts, who will represent the person and their preferences. Many times we have children who will say, I have a medical power of attorney, so I can do what I want. And we have to tell them, no, it's not what you want. It's what your mother or father wished that they want. It's not your wishes or your preferences. That is for you, but for your parent, it is what they want. And who will be your spokesperson when you cannot speak for yourself? So many times we have patients who have many children, but they will choose only one of them or two of them, or sometimes they even, despite having children, they choose friends or a sister or another relative because they do not trust that their children are going to do what they want. the preferences and wishes are basically, culture, our spiritual values all influence what our preferences and wishes are. So types of decisions that need to be made, considering those decisions ahead of time and letting the family and healthcare team know. It's all about preferences, values, and wishes, and what a person wants and how they want to live. So one thing is, this is the only legal document where the word of mouth has more value than a legal document. So one of the things our patients are afraid that if we have it written that they can't change their mind, and you can assure them that word of mouth is more. So even if they have the legal document and they've said that they don't want any treatments, but at that time when they are in pain or they feel that they do want to go to the hospital, they do want the treatment, that you would still go with whatever they say by word of mouth. We've had even patients with do not resuscitate orders, and then they've said, no, I do want to be resuscitated, and you would do what the person asks you to do. So the shared decisions are basically, one important decision is about resuscitation in case of natural death versus wanting to be resuscitated. Decisions about feeding, if they've had strokes or dementia or Parkinson's or conditions where, eating by mouth becomes a problem, would they want a feeding tube or not? And I do tell all our patients that there's no right or wrong decision at all over here. It's all about what you would prefer and what would be in alliance with what values you have in life. About hospitalizations, especially the 85 and older, many prefer to get all their treatments at home and really don't want to go to the hospital. While others do say that, no, if I can get better, I do want to go to the hospital. So asking their preferences about hospitalizations. And each one of these can go further in depth, like they may say if it's a pneumonia or something, I don't want to go to the hospital. But if it is like if I'm having a heart attack or I'm having a stroke, then I would like to go to the hospital. But having these conversations. So these are broadly the categories in which we do have the conversations with them, but each person is different. And as physicians, we are healthcare team members, we want to see like which of these decisions are more important for us to have a discussion with our patients. So how we make this possible in our practice is whether we are doing a home visit or the patient is in front of us in the clinic, we first ask them whether they have any of this. We give them the packet and we give them a brief introduction to it. Then the next time we talk a little bit more about it, and we look at their readiness, whether they really want to talk about it, they want to make any of these decisions. And of course, everybody who has a wellness visit, we do have a discussion about the advanced care planning for them. And many will say, yeah, they do want to have, but they want other family members to be involved and to be a part of the discussion so that we can, they can make decisions as a family together. And we do have specific visits just to discuss advanced care planning with them. Treatment choices, whether they want treatments that will actually focus on quality of life and comfort, or they want treatments to take care of that the condition. And many will say, oh, I don't want anything if it is IV. Many of our patients end up having cancers and they'll say, well, I don't want any chemo or radiation, but if they can take out the cancer by surgery, I don't mind, or it'll be vice versa. So discussing all the treatment choices with them and getting information on what their treatment choices are. Blood and blood products, if myelodysplastic syndrome is quite common in older adults, and then talking about blood and blood transfusions with them, or anemia of chronic conditions, and if they needed blood, would they want it? And some of them will say, well, if it is going to be once or twice a year, I don't mind getting it, but if it's going to be that I have to come in every month or every 2 weeks to get it, then I really don't want it. Then about dialysis, especially for our diabetics, if they need it. So having a discussion and asking them about what they want about that. Many times pacemakers, patients think that they don't want it, but it may actually help them to live better and have a better quality of life. So giving them education and talking about pacemakers. Talking about donation of organs, we take care of a lot of persons with dementia, and there's really very little known about dementia, although a lot more than what we knew about 2 decades ago. But the only way to learn more about it is to actually study the brain. And so talking about brain bank and donating the brain to science to see about what is the pathophysiology of dementia and how we can prevent it and how we can treat it. The spiritual preferences is really very important to ask. I know we don't get a whole lot of training on spiritual preferences, and many times patients mistake spirituality for religion, and really spiritual health has nothing to do with religion, although for many it plays a big part. But talking about their sense of what is their sense of their spiritual health, how spiritually healthy they think they are, and what's important for them, are they keeping themselves?
You already set up.
And then participation in research, what are their interests in participating in research, and what's their advanced care planning. Well, many patients with cancer also will say, yeah, we don't mind participating in research, contributing to the science. Many of our persons with dementia also agree to participate in research. So asking all this is a part of shared decision making and understanding the person's preferences, values, and wishes. So again, just to reiterate, an out of hospital do not resuscitate is only when natural death has occurred and allow for natural death. So many times patients ask, oh, I have my advance directives, and in that it very well says that do not resuscitate. Why do we need an out of hospital do not resuscitate form also? Well, it's the advanced directives they have is advanced directives to physicians, so is legal and plays a role in any healthcare setting. But if something happens to the person at home and the first responders come to assist them, they do need an out-of-hospital DNR in case the person chooses not to be resuscitated for Texas state. So it's really important to have the out-of-hospital do not resuscitate if that is what the person wants. So when, where, and how to start, so as primary care team members, I think it's important with the diagnosis. Now, we may have patients who come with all these diagnoses, asking them what is their understanding of the disease and how the disease affects function and quality of life, and what is most important to them. What matters most to them, what are their preferences. And if somebody has a family history, for example, a family history of diabetes or dementia or Parkinson's, you want to really ask about the preferences and what was the experience of the family when taking care of the person with the family, with the problem. It's never too late to have the discussion. So we get patients who've been seen by so many more other health professionals and finally come to us for primary care in their 80s, 90s. And we start asking them about preferences and all that based on, who the person is and what they are. But I think the earlier in life that we begin having these conversations with our patients, especially with chronic conditions, the diabetics, hypertensives, heart disease, COPD, giving an understanding of what the condition is and how it is going to affect the life and what choices they can make. Because I think both the healthcare team members have a role to play, but the person and family have a role to play too. And whatever we do, the person and family, the person is not going to get better or worse just by what we do. They get better or worse based on doing their part as well. So it takes two. So it's important to have these conversations and clarify roles and responsibilities and expectations. So letting the patient, getting an understanding of what's the patient's awareness of the diagnosis and prognosis, what present or future experiences are most important to live well at that point in life for them, what fears or worries about the illness or medical care they have, what sustains the patient family during serious challenges in life, and is there anything that would be worse than death for the person, to try to get an understanding of what their preferences and values are. So sometimes patients don't like talking about it. And so we tell them, like, I know this is not what you want to hear, but this is what you really need to hear so that you can live well and we can honor what's important to you and your independence, your function, your ability to live by yourself. And then they'll be a little willing to talk about it. And then as we're talking, we tell them, okay, do you want me to still go on or you want me to stop here? And then also asking, okay, tell me in your own words, what is your understanding of what we've discussed so far? And many times we've heard patients, and we know it's not true, but that's what they hear. Many times they'll say, oh, nobody ever told me that my diabetes is going to affect my kidneys and my vision and my heart and my brain, my memory and everything. And so, telling it once or twice is not going to work. I think they need to hear it every time. They need to, in different ways. It doesn't have to just be verbal. It can be posters. It can be videos that are in the waiting room for them to see, or while they're waiting for the physician or a PA or healthcare team member to go see them in their offices. There have to be posters or education material that's relevant to them, something that they can understand, that they can, get a better sense of what's their diagnosis and how it is going to progress and what's their responsibility in this. So basically, as physicians and healthcare team members, I think it's our responsibility to educate and be transparent. Many times we are not comfortable sharing the truth. And so we just tend to keep quiet because we are not being asked to tell what to expect. But I think as healthcare team members, being really very transparent and letting them know, as I said, I know this is not what you want to hear, but this is what you really need to hear to help you make choices and make decisions for you so that you live according to what's important to you. And then listing resources, it's great that we have team-based care now and more like a virtual teams with community resources that we can use, listing the resources, but not enough to just list, also making sure that we follow up with them on, the resources we've given. So did you check that out? Have you gone and, seen? Have you attended the diabetes support group, or did you enroll in the senior center and participate in that cooking class or exercise class? And building your team. So it's a virtual team that you need to build. Everybody really doesn't need to be in the same place. Giving choices for treatment options, and many times they'll end up asking, so what would you do? I said, no, it's not my life, it's your life. My preferences are different. I want to know what's important to you and what is it that you choose to do. But I also tell them there's no right or wrong. You can choose to do this now, but later if you change your mind, you may want to try the other option also. And also telling our patients about research and clinical trials, because giving them other options. For the patient and family care and caregiver, it is important to list who is important, who needs to be a part of the decision, to help make their wishes known, and then identifying the medical power of attorney, legal planning, and financial planning. So how have we made this possible? We have an approach which is now published in the Annals of Family Medicine, this July-August journal. I think it's embargoed right now. July 24th is when we would see it. Is the Cariños, and this is a term that one of our patients came about. We used to call it as the UT senior healthcare model, but we felt like it never brought the heart of what we do. And so this is what it stands for. Everything that we do, coordinated, comprehensive, advocate for our patients, respect what's most important to them. We've intentionally redesigned processes and activities to meet. So more than 50% of our visits now are home visits, because that's really what our patients need. Nurtured relationships with families, but also with community resources, with consultants, home health agencies, hospice agencies, and listening to our patients, because they know what they want and they're really very wise. So it's better to provide care based on what's important to them. And supportive care for patients and families, because as we get older, it's life. You live with chronic conditions. It affects how you live, and there's a lot of support you need. Just like how we start talking about advanced care planning, once they have a diagnosis or a chronic condition and you're trying to get an understanding of what they know and what we need to let them know. I think supportive care is also, when they have a chronic condition, you do need support to live well with that condition. So everybody in this, we belong somewhere in this, either as the primary care team or an inpatient team or ER physicians, or being a rehab center, collaborating with home health and hospice agencies, centers like Alzheimer's Association, the Cancer Center, the Brain Health Center, senior centers and DME, even APS, I've been called, and the consultants. You know, everybody has a role to play in this, and it's really a complicated network, but communication is the key. So, and nurturing relationships. So like we used to have about 20, 25 agencies, home health agencies. Now we just basically collaborate with 2 or 3, same with the hospices. Rehab also, we just focus on only Reeves or Warm Springs so that it's easier, or Morningside and Sorrento. So just establishing your network. And how we establish this is we asked our patients which are the main places they go to. And based on that, and who are the doctors that they go and see, or which are the community organizations. And we also went for these networking activities for seniors, and that's how we try to identify a lot of our resources for senior patients. So basically, if we understand how to put all of this together, if you say you have a diabetic or you know, and how many years they've had, or whether they've come here the first time, as I mentioned, you just start with, you know, I ask simple questions like finding out more about the person. What is a day for them like? What keeps them going? What brings a smile to their face? What is their motivation for life, you know? And then focusing on the M's, like, you know, what's their meaningful socialization, and screening them for depression and cognition. Doing an extensive review of medications. We use our pharmacist and her students in the clinic to help with our patients with polypharmacy. Assessing the mobility and function. So we train our MAs and LVNs to do a little bit of the timed up and go and ask all the ADL and IADL questions. And we focus most with what matters most to them and establishing the relationship with the patient and family. So there is this website is really good. It is also in many different languages and very simple to help have the conversations and even give education material to patients and families to start talking about advanced care planning. I'm not going to click on the link because I don't want to lose our presentation, but I think you do have the presentation handy to look at it. It's available in, I think, 17 different languages as well. I've used it in Korean and Vietnamese, Chinese, since we have some of those patients, and quite a few different Indian languages as well. Epic also has a tool. I know UT Epic has it. I'm not sure if UH Epic has the advanced care planning tool that helps to have these conversations. So I cannot end a talk on advanced directives and advanced care planning without talking about supportive care. So there's a lot of support that's needed, and the support is more in terms of a team and focus also on spiritual health. So I would say like social work, counselor, you know, doesn't necessarily have to be a spiritual counselor. Nursing and physician or PA would really help and educating and letting our patients know what to expect, and how helping them basically make informed decisions, because these decisions on how a person wants to live is not the healthcare team member's decision. I think it's a shared decision based on what are the values and preferences of the person. So basically focusing on person-centered goals. Each person is different and their goals may be different. Focusing on what is important for them may not be incongruent with who we are and what we would prefer, but we are providing care that's important to the persons that we care for. Focusing on quality of life and not the diagnosis. Many patients have the tendency of making life all about the disease, all about the cancer, all about dementia, all about Parkinson's. Trying to trace them back to it's life. Just understand what the disease and how the disease is going to affect your life and how you can plan and live better. Advanced care planning is for living and it's not for end of life. And basically, hospice has a very negative connotation. So I did want to share about it. It's basically hope for life, as long as you have it, opportunity to do the things that you can do as you're living, the support you need to live well. Is each person is going to be different, and it's team approach. See which of your team members you need to use and get to assist you with taking care. Compassion, so care that you would want for yourself or your family member. That way it helps us to understand the person better. So by focusing on advanced care planning, we're really saving the person, any emotional trauma and all that. I think we are respecting the person. We're providing care that's congruent with their values and wishes. It's very patient and family driven, and it's more likely to be implemented and followed if we basically engage them in how they want the care and what care they want. It improves the experience of not only the patient and family, but also the healthcare team, especially in difficult situations. Improves the quality of life, improves health outcomes, increases awareness about choices, reduces the costly ambulance calls and hospitalizations, and allows people to live with respect and dignity. We've shown, so we have like a home-based palliative care program for especially our 85 and older, or our persons with advanced dementia, where all the care is provided at home. And once they enroll in our program, we see them every week for 4 weeks to understand what their needs, preferences, and all are. And after that, the frequency of how often we see them in their homes is based on who the person is and what their needs are. And this is just about, earlier hospice care was just more towards the end, and was just a benefit in the last 6 months of life. But now if you go to palliative care sooner, you're providing support longer and the quality of life is better. So basically planning for life, understanding the person's wishes and preferences. The sooner you start, the better, and it's not a one-time conversation. You keep having these conversations and understand your role. I mean, I think patients hear only what they want to hear. So making sure that they've heard us and having them teach us back to make sure they've heard it. Using the team actually to help with these shared decision makings and engaging families. And it's going to really have a better impact. Many people tell us, don't you feel tired of what you're doing? I mean, what you're doing is so complex. And you look at the smile at the patient's face or the relief in the daughter's voice when they've got you on the phone or they've heard back from you. I mean, it just makes you feel good. It's like paying it forward. I think we do have time if anybody has any questions. We still have 7 minutes left. I can stop share and just open it out to questions.
Dr. Patel, thank you for the presentation. I have a quick question.
Yes.
Because the Family Health Center is a primary care clinic, our visits are not as long compared with your clinic. Do you have any tips on how to incorporate some of the concepts or strategies you recommended for taking care of our patients that are elderly?
So one is, I think we say like have separate sessions just to see older adults instead of including them in your routine of 15 minutes and 30 minutes, and make those visits a little bit longer. Like just like how you have the clinics for the anticoagulation and then the BHC clinics, you can have separate clinic sessions just for older adults, or the well child. We have for well child also separate. And using all the team members, so let these be not just physician visits only, deciding on what the person needs. Some may need more of nurse education or behavioral health, or maybe promothoras, and seeing how to engage promothoras a lot more too. Like we have a lot more of our patients actually having advanced directives because our promothoras have helped understand our patients' values and preferences. So with our home visits, we do team a promotora to come along with us. Either they go a little in advance and then we have the visit with us and they stay back a little bit more. They also go in between the visits to just, be the support for the patient and family. And then they bring back, all the dynamics within the family, what's happening, like the daughter that's not there or the son that's not there is not allowing things to happen, or is actually the person we need to talk to get better sense of how to help the person or family. But what has worked is really having clinics separate, and maybe think of home visits, because it's much more meaningful for older adults for us to actually go into their space and give them more specific advice to them over there. So I don't know. I know residents do some home visits, and maybe the home visit should be for older patients so that you can give them the time for it.
Thank you.
Dr. Patel, this is Byron Hepburn.
Yes, Dr. Hepburn.
That was an excellent presentation. I actually, it's a question also to add on to what Dr. Shi was just asking. Can Dr. Obaid's team help with this regard as far as initiating these conversations?
Yes, they definitely can. So it actually, whoever is the primary care or has the most number of visits with the person is the best person to start the conversation with. But then saying that, so and so from my team is going to spend, I know these decisions are hard to make and take a while. So and so from my team is going to be visiting you and going to be having these conversations. So with here in our practice, we have MDs and nurse practitioner teams. So I generally start, or Dr. Davila or Anemiki will start the conversation. And then we have one nurse practitioner teamed with us with the patient, so the patient doesn't see so many different people. And then the nurse practitioner will continue the conversation, and it's a team effort. We also have two good care managers, both LVNs in the clinic, who have the phone conversations with them. And we have one promotora, Crystal Orande, she's very quiet and introverted, but very good with patients and family. She gets us all what's important that we need to know in having these conversations with them. I think the concept of using a lot more promothoras and community health workers is not just unique to South Texas, but a lot more primary care practices are using community health workers as engaged team members for these important conversations, because I think the person and family does not feel intimidated when they're talking to one among their own community. No.
And Dr. Patel, one quick comment for the residents. You'll be surprised. Well, it'll be interesting when you see how many of your patients, to include cancer patients, have not had these discussions. Now, I know for a fact, like the Mays Cancer Center, they talked to them about this, but it'll be with your trust that Dr. Patel alluded to and confidence in you that you'll really be able to move this discussion forward. So it's so important, not only for cancer, as was mentioned, but other chronic diseases. But thank you so much, Dr. Patel.
Yeah, even diabetes, I think we see a lot of diabetics who end up having amputations and dialysis. But if we had these conversations with them sooner, I think they would really make that change. And it's not just on us as physicians or, we have a big team. See who in our team can help us. Having team visits also for our for the bigs, we do have team visits where we have the social worker, we have our promotora, we have us as geriatric and palliative, we have the neurologist and occupational therapist. So having like team visits, and you can have it as a pilot, pick it up for a few of your patients who are constantly in the hospital or ERs or needing support, and try a team-based comprehensive care for them. And then you'll know which team member needs to work a little bit more with the person and gain that trust and help the person and family. Well, welcome to the new batch of residents. And I hope to see you all coming over here to the geriatrics clinic or the hospital rotation. Thank you all.
Thank you, Dr.
Thank
Patel.
you, Dr. Patel.